Okay, class. So today we are going to be discussing diseases that affect the lower respiratory tract and drugs that treat those. This is covering chapter 5 in your Lilly book because we've previously covered other respiratory tract illnesses such as the upper respiratory infections and drugs that treat those. So we're just focusing on lower respiratory tract today. And for time purposes, if you will refer to your readings in chapter 5 and learn about the diseases that affect the lower respiratory tract and really the specifics on these drugs, we're just going to kind of hit the high notes today for time purposes. So, a basic overview. We're going to touch on the diseases that affect the lower respiratory tract, as well as bronchodilators and non-bronchodilators, which are two of the subtypes of drugs that treat lower respiratory tract diseases. So the diseases that affect the lower respiratory tract, you've got asthma, and then under the big umbrella of COPD, you have emphysema and chronic bronchitis. Each one of these diseases involves the obstruction of airflow through the airways. Chronic bronchitis and emphysema are collectively known as COPD, but if asthma is persistent and after treatment, if it continues to persist without improvement, it can also be known as COPD, which COPD stands for chronic obstructive pulmonary disorder or disease. Like I said earlier, due to the limited time that we have, if you'll refer back to chapter 5 in your Lilly textbook for the patho and just the specifics regarding these diseases. So the first class of drugs that we're going to focus on today is bronchodilators. So bronchodilators are used for all of the COPDs, asthma, chronic bronchitis, and emphysema. These drugs relax the bronchial smooth muscle bands and dilate the bronchi and bronchioles that are narrowed as a result of the disease processes. There are 3 classes of bronchodilators, and those are beta agonists, anticholinergics, and xanthine derivatives, and we're going to touch on each of those today. So the first class that we're going to touch on is beta agonists. These are your drugs that are used in acute asthma attacks, so the acute phase of your asthma attacks. They stimulate beta-2 adrenergic receptors, and there are 3 subtypes of beta agonists. So you have your non-selective adrenergic drugs, which are your epinephrines. You've got non-selective beta-adrenergic drugs, which are less common drug called metoprolol, and you've got a selective beta-2 drugs, which is your very commonly used albuterol that we are familiar with. So these drugs reduce airway constriction and restore airflow to normal. Agonist is also another word for stimulator, so make sure you write that down and know that agonist is a stimulator. So they stimulate the receptors, the beta-2 adrenergic receptors that are located throughout the lungs. So they specifically work on the lungs. So adverse effects of beta agonists. So for the first subclass, the non-selective adrenergic, which would be your epinephrine, you've got insomnia, restlessness, anorexia, vascular headache from vasodilation. You've got hyperglycemia, tremor, and cardiac stimulation because epinephrine, we know it increases your heart rate, and so it can kind of make you have the tremors, your heart rate increases. And then for your non-selective beta-adrenergics, which was your metoprolol, you have cardiac stimulation as well, tremor, anginal pain, or vascular headache, so some similar side effects. And then your albuterols with your selective beta-2s. Albuterols are Proventil, Ventolin, those are common albuterols. You've got hypotension or hypertension, vascular headache, and tremor. The half-life of these medications are fairly short, but overdose can be treated with a beta blocker, and you want to monitor these patients very closely if they overdose, because beta blockers are typically contraindicated in patients with asthma or constrictive lung diseases. But just remember, Any patients, that have any side effects or adverse effects from these drugs, your ABCs come first. Airway, breathing, circulation. You always want to make sure that those are treated first before you take care of your hypertension, hypotension, anorexia, restlessness, anything like that. So make sure that you assess your airways and breathing and circulation before you touch on the less serious side effects. So nursing implications for beta agonists, you want to perform an assessment before initiating therapy. So you want to make sure also that the patients take these medications exactly as prescribed, that they don't miss doses or double up on their doses. You want to make sure that, and there are also plenty there's lots of patient education with any medication that you give. You want to monitor the therapeutic effects of these medications. So therapeutic effects would be decreased dyspnea or decreased shortness of breath, decreased wheezing, restlessness or anxiety, improved respiratory patterns with return to normal rate and quality. So they're having regular respirations, and improve activity tolerance. So if they were, having shortness of breath on exertion before, now they're able to walk to the mailbox, without giving out. And patient education, like I said, very important, especially if you're using any type of inhaler. You want to teach these patients how to use a metered-dosed inhaler or any type of inhaler. Make sure that they understand. You can see page 569 in your Lilly textbook for proper MDI administration and how to use inhalers. Educate the patient to report any unwanted side effects. Very important to adhere to the medication to receive proper, therapeutic effects. Also, lifestyle modifications. They want to avoid the irritant exposure, allergens, quit smoking, avoid cigarette smoke, dust, etc. Adequate fluid intake, promote rest, excessive fatigue. If exercise produces their asthma symptoms, have them, make sure that they are not exercising excessively and producing these asthma attacks. And then we want them to, be compliant to the treatment regimen. The next class of bronchodilators are anticholinergics. These prevent bronchoconstriction via indirect airway dilation. These are not for acute use. Okay, so these are more long-term use for prevention. Okay, associated with chronic bronchitis and emphysema because their effects are slower and more prolonged as opposed to the beta agonists. So examples of these are ipratropium or Atrovent, tiotropium or Spiriva. You may hear of those in practice. So some adverse effects of those are dry mouth or throat, very common, nasal congestion, heart palpitations, gastrointestinal distress, constipation because they're retaining fluid, headache, coughing, and anxiety. Many times these patients are treated with combination drugs that contain beta-2 agonists, so what we just talked about, and anticholinergic drugs, so an albuterol and an ipratropium. So those are called Combivent or Duonebs. You may hear of those in practice, so those are very common. The third type of bronchodilator we're going to discuss today is xanthine derivatives. These cause bronchodilation by increasing levels of CAMP. It's an enzyme in the body. They're used for prevention, again, not acute attacks. An example of this would be theophylline. We don't really see it a whole lot in practice. If you will turn to page 571 in your textbooks, you can view drug interactions on those. Adverse effects of these include nausea, vomiting, and anorexia. And you will be tested on the drug interactions, so make sure that you do review those. Moving on to non-bronchodilators. So these don't dilate the bronchi and the bronchial systems, but they are used to treat lower respiratory tract diseases. And examples are corticosteroids and leukotriene receptor antagonists, or LRAs. So LRAs They're used in chronic treatment of asthma in adults and children over the age of 12. So again, these are not meant for the management of acute asthma attacks. An example would be Montelukast or Singulair, very common. You'll hear of that in practice. There's very few adverse effects and drug interactions. You want to, but you do want to monitor liver function, and you want to monitor liver function beginning therapy and on a regular basis during therapy to make sure that there's no liver enzymes elevated. Singulair is also approved for use in children ages 2 and older and for allergic rhinitis. So you will be tested on that, so make sure you know. Nursing implications, like I said earlier, you want to monitor liver function, and then patient education is always very important. You want to teach the patient the purpose of therapy, why they're on this medication for the chronic management of asthma, not acute. Don't take this, when you're having an acute asthma attack. They should see improvement in about a week. If not, they need to return, we need to maybe try something different. And then they need to check with their doctor or nurse practitioner before taking something over the counter, because there are many drug interactions with this, or they're not many drug interactions, but there can be. So they need to check with their doctor before taking something over the counter. And then the last class of non-bronchodilators are corticosteroids. These are also called glucocorticoids, so you can hear it alternated. These have anti-inflammatory effects. So they may take several weeks before the full effects are seen. Again, used for chronic asthma, never solely for acute attacks. They're used in the treatment of bronchospastic disorders that are not controlled by conventional bronchodilators. They come in oral, inhaled, and intravenous forms, so multiple different forms that we can use. Some adverse effects of these drugs are pharyngeal irritation, so irritation in the back of the throat, coughing, dry mouth. The most common is probably oral fungal infections, some thrush in the throat from the inhaled and oral form, because they can be immunosuppressive. And systemic effects are pretty rare because low doses are used for inhalation therapy, and most are pretty limited to their topical site of action, which in this case would be the lungs. So they're pretty much just working on the lungs. For the oral fungal infections, it is very important to educate. We want, after these patients use the inhaler, we want them to rinse their mouth out really well, get the infection out, because the drug actually alters the flora in the mouth and can suppress the immune system. So we want them to rinse. Nursing implications for corticosteroids. They're contraindicated in patients with psychosis and fungal infections, AIDS, and TB, tuberculosis, because they actually can induce psychosis or make your psychosis worse if you already have psychosis. So, education's very important. Again, like I said, have the patients rinse. Oral hygiene's important. Have them rinse after using the inhaler. Again, teach the patient how to use the inhaler. Meter dose inhaler, nasal sprays, there are nasal steroids. Going back up a slide, at the bottom, the types of corticosteroids, there's budesonide, which is Pulmicort, that's an inhaler. Flovent, fluticasone, Flovent, that is the inhaler form of fluticasone. Flonase is the nasal spray form. Prednisone, that is an oral steroid, corticosteroid. And then you've got methylprednisolone, which comes in oral forms and intravenous forms. Intravenous would be Solumedrol, and then the oral form would be like a Medrol pack. Okay, so back to nursing implications. The bronchodilator, if they are ordered a bronchodilator and a corticosteroid, the bronchodilator must be used before the corticosteroid in order to open up and dilate the airways, and then the corticosteroid can be taken and take effect. And that is it for this lecture. I hope you were able to learn something about the diseases of the lower respiratory tract and the drugs that treat those, bronchodilators and non-bronchodilators. If you do have any questions, make sure you read chapter 5 in your Lilly textbook. You're welcome to email me, text me, or call me. And just remember, you will be tested on all the information in this lecture and in the reading, but this lecture will be put on Panopto and Canvas for you to look back at and refer to if you had any questions. Thank you so much.